For our next segment, we're going to talk about therapeutic management of the active client presenting with hip dysfunction. A really great detailed presentation by Laura Purificato, who is the owner of Therapeutic Evolution. She's a physical therapist in New York. Laura, thank you so much for taking some time. It was a great presentation at NYSATA 2022. And I want to really get into some of the key takeaways you were talking about. First, you talked about the importance of differential diagnosis between 4 different categories of hip pathology. Run us through that real quick. What are those 4 categories and how do you differentiate?
Yeah, so essentially what we want to look at is, determine if the injury is osseous in nature. So we're looking to see if it's involving the femur, the pelvic bone region. For Osteitis Pubis, we might be looking at, an X-ray. Does it show inflammation? Is the patient having pain with palpation over the pubic symphysis area? For the femoral acetabular impingement, we'd be looking at if the patient has normal range of motion with internal rotation and that sort of thing. As far as the intracapsular dysfunctions, what we're looking at is, is there any change in the patient's hip range of motion? Do they have pain in the articular surfaces of the joint? We would look at, obviously if they had an MRI report to show any sort of, labral tear, any problem with fractures, anything like that. And then for the myotendinous region, we're looking again at active range of motion assessment, range of motion assessment strength, some of our special tests, such as the Bader, straight leg raises, what can the patient perform actively? And then for the neurokinetic testing, again, we can look at, is the patient having any sort of numbness, tingling in the thigh region? Where is it coming from? Could it be coming from the lumbar sacral plexus? And doing our special tests that way.
And really quick, going in before we go into our next section,
Sure.
Differentiation between the Osteitis Pubis, athletic pubalgia versus like an adductor strain. What are 1 or 2 things you're going to notice that's distinctly different if it's more of a musculotendinous situation?
So for the Osteitis Pubis, you're looking at the specific tenderness at that pubic symphysis junction, versus with athletic pubalgia, you're going to see some weakness in the rectus abdominis muscle, maybe some pain with palpation right where that inserts on the pubic bone. And then also you may find some radiating symptoms into the groin area of the thigh, and weakness with the hip adductors with athletic pubalgia. And then right where the adductor longus tendon inserts right onto that pubic bone, is there tenderness there? And also you see some muscle guarding in that hip adductor region with a strain. Yeah.
Awesome. And before we get into some treatment tips, you talked about functional performance testing of the hip, and you talked about what the research shows. Where should we focus our efforts if we're really looking at hip and lower extremity functional performance based on your findings? Where should we focus our efforts?
So what the research suggests is that there are certain tests that are more valid than others. So if we're suspecting that there's a femoral acetabular impingement involving a cam deformity or pincer deformity or a mix thereof, you might see a positive test on a deep squat where there's really some compression forces present. So that would be a good test for that. As far as any of the hip adductor strains, the research suggests the single leg squat test, the patient might show weakness or an imbalance in that. And then some of the other screens that we can do may involve the STAR excursion balance test, So as far as that test would test the hip adduction strength, the hip extensor strength, also would test your strength and range of motion in the joint surface. So those are some of the tests that could be done for that. And then if you're looking for more of a coordination or sequencing test, you might consider some of the agility testing.
And as you're putting that test results into action, whatever based on your findings of your evaluation, based on the findings of your functional performance testing, let's break down those 4 categories quickly and just give us a pearl of wisdom in your experience for those and treating those based on the outcomes you've seen. Let's start with just a basic adductor strain.
Okay, so for adductor strain, obviously you want to start with resting, icing. You might add a little bit of compression. If it's swollen, obviously elevation. But what I like to do, because I'm, manually therapy, come from that type of background, is I find that some of the counter strain techniques really work well. So you're really trying to quiet that pain pattern that's developed and reset the tendon issue and make it so that it's at its normal resting length. So then you can start to add some gentle passive range of motion and really get the patient to start to stretch it. But initially in that acute stage, you want to really focus on the resting and making sure that you're doing some good pain management with that. Sometimes the patient might need some NSAIDs on board and that sort of thing. And then eventually, once the pain is better under control, we can start to focus more on the strengthening aspect.
Fantastic. Now, what about difference in treatment between if you're suspecting Osteitis Pubis versus athletic pubalgia? What's common in treatment, both those, and then what are some differentiations that you might do with one versus the other?
So with the Osteitis Pubis, again, you want to do a lot of resting because it's an inflammatory process. So what the idea is to really get that inflammation out of there, and that can take some time. So you're considering the shearing forces that the patient may be having to do depending on what sport they're involved in. So you want to really make sure that they're resting, icing. As a manual therapist, I like to do a little bit of muscle energy, to see if the pubic bones are in alignment, because we don't want it to heal out of alignment. So you're looking at creating a balance, and then eventually, once that pain is under control, maybe adding some stability so that the pelvis isn't shifting as easily. So some strengthening exercises of those hip adductors is important so that the pubic bones don't shift. As far as the athletic pubalgia is concerned, initially, again, you want to do some resting, icing, making sure the patient is, taking care of that area and seeing if they have a hernia on palpation. Typically, you're not going to feel a hernia with palpation, but the patient might be afraid that that's what it is. So just reassuring them that, nope, it's an actual muscle weakness. So eventually, once the pain is under better control, we're going to start to add some core strengthening and stabilizing exercises there. So for the athletic pubalgia, we're looking at more of core stability exercises and maybe even strengthening into that hip adductor region as well.
Awesome. And then the last one, if you have, an FAI, if you've got an intra-articular hip pathology, of course, there's some things that only surgical approaches will be able to address, but non-surgically, what are some things you're looking for to help with that?
So non-surgically, we can treat this conservatively. Again, patient might need some NSAIDs on board, ice, heat if there's some muscle tightness. But what we're looking to do is to try and gain as much range of motion as we can, and to make sure that the patient isn't developing a compensatory mechanism and favoring that leg and then overutilizing the other leg, because then you're going to create other issues. So you want to try and give them some stretching exercises, maybe some very gentle joint mobilizations, joint decompression techniques manually, and then again, adding some of that strengthening in the closed chain exercises, doing some, seeing how they can tolerate it. If they can't tolerate the deep squats because of that femoral acetabular compression and rubbing, can they do something in a lesser range of motion and strengthening in that range? So just kind of modifying it to the patient's tolerance and making sure, I think the most important thing is keeping the alignment good so that they can, function most efficiently in both extremities.
I appreciate that. Great tips, and thank you for all the information you presented during your seminar this past weekend. Your contact information is in the show notes for anybody who wants to reach out to pose any questions that you might have for Laura. But thanks for taking some time and for recapping the key takeaways from your presentation, Therapeutic Management in the Active Client Presenting with Hip Dysfunction. Thank you so much, Laura.
Thank you.
Have a great day.
You too.